Hello, everyone. It's me again, Dr. Nenninger. Hopefully, you remember me from last year when I gave a lecture in your ClinPath course. So, I'll be discussing neoplasia cytology with you today. We're essentially just going to be scratching the surface of neoplasia cytology. It's really hard to cover everything you guys will need to know in 50 minutes. I spend 3 to 5 years of residency learning it. So this is just to help you guys in practice with some of the major cytologies and neoplasias that we see. So when we're looking at cytologies of different neoplasms, the questions that we want to answer are: is there a tumor present? What kind of tumor is present? And then if that tumor is benign or malignant. And so hopefully we'll be able to answer those when looking at an aspirate. We're not always able to, but these are the goals whenever we look at a cytology. So it's also important that we discuss some of the limitations of cytology. So first and foremost, some neoplasms do not exfoliate well on cytology. They just don't for some reason. When we try to aspirate them, we don't get good samples. The samples are frequently acellular, and so we just don't get a representative sample to even be able to call it a neoplasia. And this is really common with sarcomas. So another thing that can happen is with early neoplasias, like the example I think of most commonly is an early lymphoma, where maybe you have increased large lymphocytes, but there's still quite a few small normal lymphocytes present. It can be equivocal in early neoplasia, and so it can be difficult to diagnose in that case. One other issue that we come across is that cytologic criteria of malignancy do not always predict malignant behavior. So there are some tumors which look pretty normal on cytology. They have very few criteria of malignancy, such as neuroendocrine epithelial tumors, canine mammary tumors, and then some mast cell tumors. They can look really well differentiated, have very few criteria of malignancy, but behave very aggressively. So that's something to keep in mind. Another issue is that we can frequently, but not always, determine which tumor type is present. So, and by type I mean sarcoma, carcinoma, round cell tumor in the greater categories, but we can't determine which specific tumor type of those greater categories are present. So we might be able to tell that something's a sarcoma, but not that it's a fibrosarcoma or an osteosarcoma or a hemangiosarcoma. We just know that there's atypical spindle cells present. It's some type of a sarcoma, and then we recommend biopsy and histopathology from there to further differentiate what type of sarcoma that may be. And then finally, there's some non-neoplastic processes which can mimic neoplasia, specifically hyperplasia, or if there's a lot of inflammation present, say due to an infectious agent such as a bacterial infection or a fungal infection, you can get really marked dysplastic changes and reactive changes because of the inflammation and the infectious organism that's present. One example actually that I had of this was I was on service with Dr. Weil, and we got a sample of a spleen, and it was just really ugly spindle cells throughout the whole aspirate. We were ready to call it some kind of a sarcoma, like a splenic stromal cell sarcoma or something like that. It just looked terrible. And then as we started to look around more, we found the large numbers of fungal agents that were present. And so it's just important to keep in mind that inflammatory processes and infectious agents can cause these dysplastic changes as well, which can mimic neoplastic changes. So when we're deciding if a tumor is present, there's two kind of big categories that we try to lump things into. So is there a homogeneous population of atypical cells present, as we see here on the left with all of these uniform mast cells, which are present in a cutaneous lesion that should not be present in health in a cutaneous lesion? Or do we have metastatic disease, and these are cells that are just in the wrong place? And so on the right, this is a picture of a lymph node aspirate, and in the middle there, you have this cluster of these really ugly, cohesive epithelial cells. They have pretty marked criteria of malignancy. And besides that, there's epithelial cells in the lymph node. And you should never have epithelial cells in a lymph node. So that tells you right there that there's metastatic disease. And so these are kind of the two big categories. So primary disease, where there's the primary population of atypical cells, or metastatic disease, where it's spread from elsewhere in the body. So when we discuss what kind of tumor is present, we're going to be discussing these three fundamental tumor types, which are epithelial cell tumors, mesenchymal cell tumors, or spindle cell tumors, and then round cell tumors. So first, epithelial cell tumors, the cells are usually fairly large. They're polygonal in shape, so they're cuboidal to columnar. They can be found individually or in cohesive clusters, and then they usually exfoliate pretty well, so we get pretty high cellularity on these aspirates. When discussing mesenchymal cell or spindle cell tumors, these are usually small to medium-sized cells. They're spindles, so they have a round to oval nucleus, and then they kind of come to a point at either end, and they can be found individually or in small aggregates as well. And these, like I said previously, do not exfoliate as well as epithelial cell or round cell tumors. And then finally, round cell tumors. These usually have small to medium-sized cells. They're round in shape. And they're found individually or in small aggregates. They're usually not cohesive. They're usually just kind of, they can be close to one another because of how they're spread out on the slide. And then these usually exfoliate pretty well, again, on cytology. So after we decide if there's a tumor present, and we decide there is, then we have to decide if that tumor is benign or malignant. And so to do this, we look at some general criteria of malignancy. And so some of these criteria of malignancy are on this chart here, and then on the next page I have another chart which will be for your reference. But some general criteria that we use is we look at anisocytosis, so the difference in cell size between the population. So if the cells are markedly different in size, you have one that's pretty small and the one next to it is really large, then that is said to have marked anisocytosis. Another thing that we use is anisokaryosis, which I'll show you on this image on the bottom here. So if you look at this image, there are really marked differences in nuclear size. Some are much larger than others, and that's what we would call marked anisokaryosis. So anisokaryosis is the difference in nuclear size within a cell population. Something else we very frequently look at is how pleomorphic the cells are, or how variable in shape they are. So if there's marked differences in the size and shape, then it's said to have marked pleomorphism. And so again, in this image at the bottom here, some of these cells differ greatly in cell size and cell shape. They're not uniform at all, and they're forming what's called an acinar formation, which is this kind of circular formation that they're forming. And these are very common in carcinomas, actually. But so these are just some criteria of malignancy that we look at when we're assessing cells on cytology. So this slide just covers some more criteria of malignancy that we look at. This is mostly for your reference, and I'll discuss them in greater detail on the next slide when there's pictures and it's easier for me to describe things to you guys. Okay, so here I have some pictures that are good examples of criteria of malignancy. So in the upper left-hand photo, we have pretty marked anisokaryosis, so there's a lot of differences in the nuclear size between these cells. There's macrokaryosis, which means that we have really large nucleus or nuclei as well throughout the cells, usually larger than a red cell, but these are like way larger than red cells. There are some multinucleate cells over on the side. And then many of these cells have nucleoli present within the nucleus, which is bad. If we look at the top middle photo, you can see some mitotic figures throughout here. The chromatin kind of lines up along the center, and we frequently see these with more active and more malignant neoplasias. And then on the upper right-hand side, this is just an example of an abnormal mitotic figure, which is really bad. So if you have cells that are rapidly dividing because the mass is growing and it's not responding to typical growth inhibitors or regulators, it's really bad when they're not even replicating in the proper way, and then you get these really messed up mitotic figures. So that's real bad. On the bottom left-hand image, you can see the open chromatin that's present in these malignant lymphocytes. And so usually lymphocytes have much more condensed and deeply basophilic chromatin. However, when they're much more mitotically active and more active in general, they have much more open chromatin, and that's typically a bad thing. And the bottom middle image, what we see here is called nuclear molding. And so that's when we have this cell kind of inside of another cell, and that nucleus of that cell is molding to the cell that's inside of it. That's not normal, and that's not good, and that's just really bad when we see things like that. I did put one example of a benign neoplasia here, and so the bottom right-hand image shows a much more benign epithelial tumor. So these cells are cohesive, they have very minimal anisocytosis, anisokaryosis. They all look pretty uniform. They have nice dark chromatin. It's not open, it's pretty dense. And so this is just what you'll see with a more benign population. You don't have the variability that you have in the other images shown here. There's also some cytologic criteria of malignancy that we frequently look at when assessing a cellular population. And so on the left-hand image here, we have a population of neoplastic lymphocytes. And so these cells have the open chromatin that I just discussed previously. It's very lightly basophilic, and then it has this deep rim of basophilic cytoplasm surrounding it. And usually cells that have more basophilic cytoplasm are producing more proteins. They're more metabolically active because, again, they're dividing more rapidly. They need more proteins in their cytoplasm to account for that. And so they typically take a more basophilic appearance, which is just not good overall. And so that's one thing that we might look for. This middle image here is a picture of histiocytic sarcoma. And so these are round to spindle in appearance. They're very large, and they have multiple nucleoli in that nucleus there, which is not good. And there's marked anisocytosis and anisokaryosis, and it's just bad. But something else that we see here is erythrophagocytosis. And so there are red cells being phagocytosed by these histiocytes, and that's not good. So anytime we see erythrophagocytosis, that's a big criteria of malignancy, and typically neoplasms that do erythrophagocytose red cells are very aggressive in their behavior. And so that's very bad when we see that. Something else that we can see in the cytoplasm are what's called secretory products or secretory vacuoles. And so some spindle cell tumors, such as osteosarcoma and chondrosarcoma, will produce matrix, which you can see in the cytoplasm or surrounding the cells. And it's this kind of homogeneous eosinophilic material. And then what we see here is this is actually an example of transitional cell carcinoma, which is a type of epithelial neoplasia. And this kind of eosinophilic inclusion in the cytoplasm is what's known as a Melamed-Wolinska body. You guys don't need to know the name. I barely need or know the name, and I need to know it for boards. So, but they're frequently seen in transitional cell carcinoma. And so if we have a sample that we're concerned for and we see these, it's much higher on our list and much more likely. So that's just something that I wanted to point out. And again, cytologic criteria of malignancy does not always predict biological behavior, especially on cytology. And I just really want to stress that to you guys, that it can be really difficult for us or for you guys in practice when you're looking at cytologies to always tell the behavior of a tumor from the cytologic criteria of malignancy that's seen. The first specific type of tumors we're going to be discussing are epithelial cell tumors. And so these tumors have polygonal shaped cells, so cuboidal or to columnar usually. They form cohesive clusters. They can be found individually as well, but they do typically form cohesive clusters. And they can form acinar or tubular formations. So in the bottom image here, we have this kind of aggregate of epithelial cells that's forming what we call a papillary structure. And that's very common to see papillary structures in tubular formations. And then the acinar formation that I showed you previously, which is a more circular structure that the cells are forming. And those are very commonly seen with epithelial neoplasias. They typically have distinct cell borders, so you can tell where the cytoplasm of one cell ends and the other one begins. They don't just blend in typically. So sarcomas do blend much more frequently, and so they don't have distinct cell borders. However, epithelial cell tumors typically have distinct cell borders. And then they can frequently have these secretory vacuoles within the cytoplasm, which you can see in the top image here. So these are two common skin epithelial cell tumors that behave mostly as benign. So the first is what we call basal cell tumors, and there's quite a few specific tumor types in this overall category. But cytologically, we can usually only call them basal cell tumors, and then we'll recommend biopsy and histopathology so they can further differentiate it out. But we're unable to do that cytologically. And so, again, very minimal criteria of malignancy here. All the cells look fairly uniform, very minimal anisocytosis, anisokaryosis present. On the right here, this is an example of a perianal adenoma. Again, mostly benign. There is a malignant variant of this known as perianal adenocarcinoma, but it's much less common, and it typically has much more criteria of malignancy present. So here with the perianal adenoma, we have these larger cells present, which actually look like hepatocytes, which is why it gets its second name, the hepatoid tumor. And then we have these smaller cells kind of scattered along the edge here, and those are called basal reserve cells. but it's very uniform. You have the big hepatoid cells, which look very similar throughout, and then you have these small basal cells along the edge, and that's very characteristic of a perianal adenoma, and these occur very frequently. We see them almost weekly here on cytology. So these are some common epithelial tumors, again, of the skin, which unfortunately are much more aggressive. And so the first one on the left, that is an example of squamous cell carcinoma. These are very common in horses and in cats. They have this typical fried egg appearance, people say. So they have small centralized nucleus and then kind of abundant, lightly eosinophilic cytoplasm. They don't exhibit marked criteria of malignancy typically cytologically, but they're always pretty bad. So these guys don't tend to metastasize as readily, but they are very locally invasive. And when they do metastasize, they typically go to regional lymph nodes via the lymphatics. This middle image here is an example of apocrine gland anal sac adenocarcinoma, or Agasaka. And so this is an example of a neuroendocrine-like carcinoma. And so these are one of the examples where its criteria of malignancy does not match how aggressive it behaves. So here, there's very little criteria of malignancy. There's very mild anisocytosis and anisokaryosis. You have this cluster of epithelial cells, and then you have a few bare nuclei over in the upper right-hand corner. But overall, it doesn't look very bad. These behave very aggressively, though, so it's unfortunate that they look so benign but behave so aggressive. So that's just something to keep in mind. And then when we discuss mammary tumors on the right here, so mammary tumors are very difficult to assess on cytology. If we see really marked criteria of malignancy in the sample that we get from a mammary tumor, then it is much more likely that it's malignant. I believe in a study that was recently done, I think 90% of mammary tumors that had marked criteria of malignancy on cytology were actually malignant when they were biopsied and evaluated on histopathology. However, when they looked at mammary tumors that had a much less criteria of malignancy, so looked much more benign, apparently we only got it right 50% of the time. So 50% of those benign-looking mammary tumors were malignant, and 50% were benign. So it can be really hard to assess the behavior of a mammary tumor on cytology. We very frequently recommend biopsy and histopathology. We pretty much always recommend it for mammary tumors, just because they can be so challenging cytologically. Okay, so moving on to spindle cell tumors. So spindle cell tumors have spindle-shaped cells, go figure. Some people also refer to them as stellate or fusiform, but so they have a round to oval nucleus, and then they have minimal to moderate amounts of cytoplasm that come to kind of points at either end. They're found individually or in small aggregates, and they typically have ill-defined cell borders. So if you have an aggregate of them, you kind of can't tell where one cell begins and one ends, and there's just these nuclei, and you just can't tell whose cytoplasm belongs to whom. They also typically exfoliate very poorly. There are some types that exfoliate well. However, overall, as a category, spindle cell tumors do not exfoliate very well. So it's just important that you guys know that. They do sometimes have matrix associated with them. So again, like I discussed, the chondrosarcomas and the osteosarcomas will frequently have matrix associated with them, such as osteoid, and it'll look like an eosinophilic kind of homogeneous material scattered throughout the cells. Spindle cell tumors can also be called mesenchymal cell tumors. So it's an interchangeable name, and you can refer to them in either way. So some common skin spindle cell tumors. When I think of skin spindle cell tumors, I pretty much think of soft tissue sarcomas most commonly. And that's a much broader group of spindle cell tumors that we see. There are specific ones under the soft tissue sarcoma umbrella, but we have a very difficult time on cytology differentiating different types of soft tissue sarcomas. So typically, if I read out a cytology that has atypical spindle cells and I'm concerned that it's a soft tissue sarcoma, I'll just call it a soft tissue sarcoma in my interpretation, and I can't get any more specific than that, such as fibrosarcoma or perivascular wall tumor or schwannoma or something like that. We typically leave that to the histopathologists because they have the tissue architecture to work with and they have much more detail than we do. Some of these soft tissue sarcomas do exfoliate pretty well. So the perivascular wall tumor or the schwannoma do tend to exfoliate well, and so we'll see numerous spindle cells with those two tumors. However, there are quite a few that do not exfoliate well, such as fibrosarcoma, fibromas, liposarcomas, and others. And so that's just important to keep in mind, that if you aspirate a mass that you're concerned might be a soft tissue sarcoma and you don't get a good sample, it might not be you. It could very well just be the type of lesion that's present, and you might be better off biopsying it to get a definitive diagnosis. These soft tissue sarcomas typically are regionally invasive, but tend to metastasize much less frequently. That being said, on histopathology, they have a grading scale for soft tissue sarcomas. Overall, the majority of them are low grade, and so they tend to not metastasize. However, the ones that are high grade do metastasize readily, and so that's important to keep in mind. If you do biopsy a soft tissue or a mass that ends up being a soft tissue sarcoma, it's important to pay attention to the grade of it, because that changes the clinical behavior pretty significantly. So a couple other spindle cell tumors that I wanted to discuss are chondrosarcoma, which we see in the right image. And so with this, we have these atypical spindle cells, which the borders are hidden by all of this eosinophilic matrix that it's producing, which is very common to see with chondrosarcomas. And so this was just a really beautiful image, I thought, and so I wanted to share it with you guys. This is a really good example of what a chondrosarcoma can look like with the matrix and the atypical spindle cells present. The image on the right is an example of a hemangiosarcoma. I will tell you that hemangiosarcomas do not exfoliate well at all, which kind of makes sense. It's just a ball of neoplastic blood vessels that are arranged in a haphazard manner and just a disaster. And so the cells themselves don't exfoliate well, and so we tend to just get blood on the samples where people are suspicious of hemangiosarcoma. I think in the 2 years that I've been here, I have diagnosed sarcoma in 2 cases where it ended up coming back as a hemangiosarcoma, and we get about probably at least one a day, one spleen sample a day, where a clinician's concerned about hemangiosarcoma. So we very, very uncommonly can diagnose these on cytology just because they exfoliate so poorly. But since they are pretty common and an anatomic path, I felt like the answer to everything was hemangiosarcoma when I was a vet student. I wanted you guys to have a picture of what it would look like. And so what you have here are really atypical spindle cells that have indistinct cell borders. There's pretty marked anisocytosis, anisokaryosis. There's multiple nucleoli of different sizes scattered throughout, and they just look really bad. So two other processes that fall under the sarcoma umbrella are sarcoids in horses and feline injection site sarcomas. And so equine sarcoids are not, they are malignant, but they're not. They're just different. And so they're very locally invasive typically, but they do not metastasize. And so it's important that if we diagnose one of these, or if you get a diagnosis of one of these, maybe remove it when it's smaller versus larger, because they are locally invasive and it'll be much harder to remove once they get to be very large. These sarcoids tend to occur in areas where there was previous trauma. They tend to be in younger horses overall, and there is thought to be some involvement of the bovine papilloma virus that may cause this. However, it's not certain the role it plays at this point, but it is thought to be involved. And then when we discuss the feline injection site sarcomas, so it's not just associated with vaccines anymore. They can be associated with any injection. So a vaccine or a treatment of some kind, anything that they get an injection for can cause this, and that's why we recommend to give the injections on the lower part of the back limb now, because when we were giving them at around the shoulder area, it's much more harder to remove because these are very locally invasive and they metastasize really readily. So it's much harder to remove a large mass on the trunk of an animal than it is to amputate the lower limb of an animal. And I'm sure you guys have learned that throughout your time here, but I just wanted to stress it again because we do still see it with some frequency, and so I just want you to be aware that it still happens and it's always bad. The image at the bottom is from a feline injection site sarcoma, and this is a really ugly sarcoma, marked criteria of malignancy, really ugly spindle cells. So I think hopefully you guys get the gist of it by now. So the last cell type I'm going to discuss are the round cell tumors. And so these are round in shape, go figure. They can be spindeloid rarely. So with things like histiocytic sarcoma, you can get round to spindeloid cells. So that's just something to keep in mind. They are usually found individually or in small aggregates. They're not usually cohesive is the difference. So they can be found in aggregates, but they're usually not adhered to one another like we see with epithelial cell tumors. So that's something to keep in mind. They have well-defined borders. They tend to be very highly exfoliative, so they're very rewarding on cytology when we aspirate round cell tumors. They're from hematologic in origin, and then they can also be referred to as discrete cell tumors. In ClinPath land downstairs, we tend to not call them that. However, some people do, and so if you ever hear that term, I wanted you guys to be aware of what that was referring to. So we're going to discuss some common skin round cell tumors that mostly behave as benign first. And so on the left, we see a typical histiocytoma on the inset on the bottom. That's what they look like grossly frequently. They're described as a classic cherry lesion, usually on the muzzle, the ears or the limbs of a dog. And what we see cytologically is these round cells, which have usually a centralized nucleus. They have moderate to abundant, lightly basophilic cytoplasm, which sometimes can have scalloped edges. And then they can have what's called a cleaved nucleus, so it can be like indented with a line down the middle, and that's something that you can see very commonly with histiocytomas. If you look at the right, this is an example of a plasmacytoma. And so one thing that we very commonly see with plasmacytomas is an eccentric nucleus. So it's off to one side and the cytoplasm is on the other side. One other thing that we can see is the little clearing. So on the inset on the bottom left picture, there's these little pink kind of areas in the cytoplasm, and those are what's referred to as a Golgi zone, and those are also a very common detail for plasmacytomas. So with these two images, it makes it seem like it's pretty easy to tell them apart all the time, and that is not the case. There are plenty of times where it's very difficult to tell the difference between a plasmacytoma or a histiocytoma. Even though they are mostly benign, sometimes plasmacytomas can represent malignancy in the form of multiple myeloma, so not always benign. So if we have a lesion that we think is a histiocytoma, they should usually resolve within 3 months in younger animals. If it's an older animal, they don't always resolve. So it's just important to keep an eye on it. And frequently, if I tell clients that if it enlarges or just doesn't go away, that there's nothing wrong with removing it and sending it in for histopathology just to confirm the diagnosis. So better safe than sorry. And histiocytomas do typically occur in younger dogs much more frequently. I believe 2/3 of them occur in young dogs. However, 1/3 of them do occur in older dogs. And so it's not impossible to see a histiocytoma in old dogs. They happen with some frequency and some regularity. So just so you're aware of that. So mast cell tumor time. So mast cell tumors are very common. We see them all the time on cytology, but they can look very different depending on the tumor and what's going on. And so this first image in the upper left-hand corner is an example of a well-granulated mast cell tumor. And so you see these round nuclei, which have lightly basophilic nuclei, and then abundant purple granules all throughout the cytoplasm, sometimes covering the nucleus as well, but you can see all the granules. You can see that they're mast cells for certain. And so these are the ones that are pretty easy to diagnose. I really like reading these out on cytology. It gets to be a bit more difficult when you get over to the upper right picture here, and we have very poorly granulated mast cells, and so we just have a fine dusting of these purple granules. There's also way more criteria of malignancy present here. There's very open chromatin, there's marked anisocytosis, anisokaryosis. There's multiple nucleoli that are different sizes and shapes. And so you can get very different appearances with the same type of tumor when you're talking about mast cell tumors. And so the overall majority of them are low grade, about 65 to 83%. However, there are some that are high grade, and those tend to behave much more aggressively. On cytology, we did have a grading scheme that was developed. However, it was found to not be very accurate in predicting the behavior of these tumors, and so we leave the grading to histopathology at this time. So when we'll always recommend removal, biopsy, and histopathology when we diagnose a mast cell tumor so that they can adequately grade them and let you guys know what the grade is. And then this picture on the bottom here, I just wanted to point out that in about 20% of mast cell tumors, they will not, with Diffquick, the granules will not stain. And so you'll see what you see here, which is some round cell neoplasia, but you'd have no way of knowing that it's a mast cell tumor because you can't see any of the granules. So I just wanted to point out to you guys that that can happen. Here in our ClinPath lab, we do not use the Diffquick stain. We use modified right stain or a Giemsa stain. And so that always stains the granules. But I know in Diffquick, many of you will be, or in practice, many of you will be using Diffquick. So I wanted to let you know that this can happen sometimes. So some other round cell tumors that we very commonly see on the left-hand side, that the top and bottom photo are an example of lymphoma. We diagnose lymphoma almost daily down in ClinPath. It's very common in our domestic species, especially dogs. And so this top photo here shows pretty large lymphocytes. They have open chromatin. They have nucleoli, multiple nucleoli sometimes throughout. They have a more basophilic rim of cytoplasm. They're very large. They should be about the size of a red blood cell to maybe 1.5 times the size of a red blood cell. And you can tell that these are just significantly larger than that. And then there's actually a mitotic figure in the bottom part of that image. The image below for the lymphoma pictures, so that's what a lymphoma aspirate stained with Diffquick looks like, and you can tell that it's just a lot harder to see a lot of the cellular detail when it's stained with Diffquick, and so it can be really hard in practice to make the diagnosis of lymphoma when you can't fully see all the criteria of malignancy that are present. So I just wanted to, again, point out that there are some issues with Diffquick, and if you guys have a hard time diagnosing lymphoma in practice, you feel free to submit unstained slides to us, and we'd be happy to read them out to see if we can maybe assist. So just wanted to point that out. The middle images here are of histiocytic sarcoma, and so these are essentially malignancies of a macrophage origin. And so these can look round to spindle in appearance, and that's not uncommon. And they behave very aggressively, especially the hemophagocytic variant. So this image at the bottom displays these red blood cells in the cytoplasm of these horrible looking histiocytes. And so this is the hemophagocytic histiocytic sarcoma, and that's just a really awful prognosis, unfortunately, for animals. So, and then the last round cell tumor type I wanted to discuss with you guys was transmissible venereal tumor, TVT. And so this does still happen in the United States. It's typically limited to the US-Mexico border down south. However, we can still see it, and so it's important that you know that. These are actually respond very well to treatment, and so they can be cured sometimes with as little as 1 dose of a chemotherapeutic agent. And so the TVTs are the most curable, essentially, of the round cell malignancies. So melanocytic tumors, they can be really tricky, and they are frequently referred to as the great mimicker. They essentially do what they want. They can look round in appearance, they can look polygonal, they can look spindeloid, so they can look like any type of neoplasia, and it can be really difficult to diagnose these, especially when you have such a variation in granularity as well. And so just like mast cell tumors can vary in granularity, so can melanocytic tumors. And so you can have the really well granulated melanocytic tumors where there's a lot of the brown to black granules in the cytoplasm. They're free in the background and it's fairly easy to diagnose it, which like the image on the left, or you can have one like the image on the right where there's maybe a fine dusting of those black granules in the cytoplasm, but it's much harder to tell. You have to go to higher mag to see them. And then you also have much higher criteria of malignancy here as well. Usually the poorly granulated melanocytic tumors are much more aggressive. The placement affects the malignancy as well, so where they're found on the body. So I feel like the malignant melanoma gets a lot of attention in veterinary medicine and human medicine, and rightfully so. It's terrible and aggressive, and we don't like it. However, we can't forget that there is a benign version of these tumors, which is the melanocytoma, which is frequently benign. And these are usually found more on the trunk of the animal, whereas the malignant melanomas are found much more at the mucocutaneous junctions or within the oral cavity of dogs and cats. And so this image on the right here is from a malignant melanoma, and there's really marked criteria of malignancy. You see, I believe it's called like an owl eye cell, where you have these two nuclei within one cell, and they both have single nucleoli present, and they look like little eyeballs staring at you. And so that's not good. We don't ever like it when cells stare at us because that shouldn't be happening. So again, these cells or these tumors can be difficult to diagnose. They can really look like anything. If you get a well granulated one, then it can be easier, but it can get really challenging. So the last type of tumor I wanted to discuss was the lipoma. Lipomas are really common. We see them all the time. However, on cytology, we cannot differentiate a lipoma from subcutaneous fat because they both just look like well-differentiated adipocytes, and that's all we see. So what I frequently tell clients is if the mass was consistent with a lipoma, so if it was soft, freely movable, and they thought it was a lipoma, then it's probably a lipoma. However, if the mass did not seem like a lipoma to them, if it was much more firm, adhered to underlying musculature or bone or something, then they may have just missed the target, and they may have just aspirated the adjacent subcutaneous fat, which happens. It's not a big deal, and I always offer resubmit for these, but I just wanted to point out that we on cytology cannot differentiate a lipoma from subcutaneous fat because, again, all you see is well-differentiated adipocytes with both of them. So these are just two reference texts that I think can be really useful in practice. The canine and feline cytology one is awesome, and I use it all the time when I'm on service. It has really nice images and really helpful information in there. The diagnostic cytology and hematology of the horse, I am not a huge horse person and I don't do a lot of horse work. However, Dr. Weil has recommended it, and I'm sure I will use it at some point. But for all my equine people out there, this is what is recommended for the horse if you need a reference text. One other thing I wanted to recommend was this website, which is the VSSO, or Veterinary Society of Surgical Oncology. And this is just a really helpful website for when you're in practice. If you biopsy a mass or send out an aspirate for cytology and it comes back as a type of malignancy that you're not familiar with, this is really a helpful site to give you prognostic information and treatment information. And it's just really helpful. So I just wanted you to have it for the future. So, hopefully, you guys learned something in this lecture and it wasn't just me rambling about nothing for 40 minutes. Um, if you guys have any questions, I know Dr. Vile or I are happy to answer them. Again, it's really hard to cover everything you need for cytology in 40 minutes or 50 minutes. So, this is just a very basic outline, and hopefully, the images are helpful. And this is my golden retriever, Olaf. He brought me like 4 toys at once because he wanted my attention. So I had to take a picture of him. But again, I hope this lecture went well. And again, if you have any questions, please feel free to email me or Dr. Vile. And have a great rest of your semester. I'm really sad that I couldn't lecture to you guys in person.